So I'm going to present a case where we've used Serenator and it was game-changing in the results. And I think it's a good example of how unique this technology is. So this is a 70-year-old male. He presented to my practice with Rutherford Category 5, chronic limb-threatening ischemia, actually of both lower extremities. Both 4 feet had extensive gangrenous changes present. He was actually post-deep venous arterialization of the right forefoot, followed by transmetatarsal amputation and subsequent healing. He presented for recanalization, plantar arch recanalization, tibio-peroneal recanalization of the left lower extremity in order to improve perfusion and follow that, hopefully, with transmetatarsal amputation. These are 2 shots from digital subtraction angiogram of his left lower extremity. This shows extensive tibio-peroneal occlusive disease with extensive plantar arch occlusive disease. The posterior tibial and the peroneal arteries occlude above the ankle. The anterior tibial artery is heavily calcified with multiple segmental occlusions. The dorsalis pedis is occluded again, as well as the deep plantar arch is occluded. These are 2 images from my initial intervention. I crossed the lesion, I was able to wire into the deep plantar arch, and I followed this with orbital atherectomy in order to modify the plaque, and I followed this with prolonged balloon angioplasty. This DSA image shows the outcome from that intervention. I was pleased with the results. We had nice inline flow through the anterior tibial artery into the dorsalis pedis. Following that intervention, the patient underwent successful transmetatarsal amputation. These are images from his initial 1-month follow-up after the angiogram and after transmetatarsal amputation. This slide shows his surveillance duplex at 4 weeks post orbital atherectomy and angioplasty. We could see that we have strong upstroke and a nice multiphasic waveform in the dorsalis pedis. The patient initially was healing well, and we were pleased with the results. However, at 3 months, he started to develop some breakdown at the lateral and medial margins of his transmetatarsal amputation site. At that point, he was scheduled for surveillance duplex of the left lower extremity. At the 3-month surveillance duplex, it was noted that he had a repeat occlusion, recoil of the dorsalis pedis. There's now monophasic waveforms and multiple areas of occlusion in the dorsalis pedis. Based on this finding, in order to help further promote healing and hopefully limb salvage, we repeated the angiogram. The repeat angiogram again shows recoil, restenosis in multiple areas of the distal anterior tibial artery, as well as the dorsalis pedis and plantar arch. Given his failure of initial orbital atherectomy and planal balloon angioplasty, I wanted to do something different in order to maximize the chance we could get this to heal. So what I did was I recanalized the occlusion of the anterior tibial and dorsalis pedis. I was able to wire back through the plantar arch, and in this instance, I employed Serenator technology. I performed Serenator angioplasty of the dorsalis pedis and the distal anterior tibial artery. You could see on this post-DSA image that we had nice expansion and nice opening of the anterior tibial and dorsalis pedis arteries. This is an image of his duplex 6 months later after that intervention. You could see that there's still patent dorsalis pedis. The final image represents his transmetatarsal amputation site 3 months after that repeat angiogram using Serenator technology. It's now been almost a year since that repeat intervention. The patient clinically is fine. He has fully healed transmetatarsal amputation site, and the dorsalis pedis and anterior tibial artery remain patent. So in summary, this is a patient who had early recoil and restenosis of below the knee and below the ankle disease. Following repeat angiography and repeat intervention using Serenator technology, we were able to achieve a durable clinical result for the patient.